All right, well, we're going to get started. Thank you. I really appreciate the great attendance. It's great to see all of you in person. And for those who are online, you're really missing out on a fun event this morning. There's been a lot of discussion in the back. People haven't seen each other for a while, so come on down. To start off, we just want to highlight our Department of Medicine Artist of the Month, Artist in Residence. And this month we are featuring Dr. Vince Crines, who is, as many of you know, just stepped down as division chief for endocrinology, and in some ways is taking up his new career in painting, which he began during the pandemic. And he just like delved into it with such passion and joy. He discovered, I like this quote, "I discovered a joy that made everything else disappear and a voice that would no longer be silent." His work focuses on nature, beauty, fragility, and meditative qualities. He breaks down complex patterns, rebuilds them using simple brushstrokes and bold colors. He has many sites. He's been featured on the cover of the Wisconsin Medical Journal, and it was a competitive process to get a booth at our art fair on the square this summer and the art market. And I don't think he's quite ready to give up his day job to take on painting full time, but close to it. We have a great painting here that we're auctioning off. There's some examples of his work. And I know he's sold internationally as well. People are acclaimed and going to his website. So come on down. If you're in your office, come on down and put your name in the raffle, and we'll pull names at the end. Next. So very delighted today to have a guest speaker from Vanderbilt, Dr. Kelly Dooley, and to do the introduction, we are excited to invite Dr. Ann Mish from our own division of ID to introduce Kelly.
Thanks, Lynn, and thanks, Kelly, for coming to Madison. So I'm very pleased to introduce to you all Kelly Dooley. She's a longtime friend, and she'll be giving grand rounds this morning. Dr. Dooley is both a clinical pharmacologist and an infectious disease physician scientist. She earned an MD from Duke University, an MPH from the University of North Carolina, and a PhD from Johns Hopkins Bloomberg School of Public Health. She completed fellowships in clinical pharmacology and infectious diseases at Johns Hopkins, and where she joined the faculty in 2010. At Hopkins, she built an extensive research portfolio focusing on therapeutics for tuberculosis and HIV, becoming a full professor in medicine, pharmacology, and molecular sciences in 2021. In 2022, Vanderbilt was very lucky to recruit her to Nashville, where she's currently professor of medicine and division director of infectious diseases. In her work, Kelly uses clinical pharmacology and insights from well-designed clinical trials to answer key therapeutic questions in TB and HIV. Examples of such questions include finding the right dosing strategy for old TB drugs like rifapentine, as well as new TB drugs such as britominid, and determining whether specific HIV regimens are efficacious in patients receiving concomitant therapy for tuberculosis. Given that 0.5% of the world population is infected with HIV, and that TB is the most common infectious disease cause of death after COVID-19, questions like these are very simply not trivial. Dr. Dooley has authored over 200 publications and chaired or participated in numerous WHO, CDC, NIH guideline committees for TB therapies. She currently serves as the chair of the WHO task force on the PK/PD of tuberculosis drugs. Along her way, Kelly has accrued numerous awards, which I will not belabor for fear of embarrassing her. She has mentored dozens of medical trainees, doctoral students, postgraduates, junior investigators, clinical trialists, and overseas colleagues. One of her recently funded grants focuses, in fact, on mentoring investigators in the TB and HIV therapeutics space. On a personal note, I've known Kelly for over 30 years. We first met at Penn, where we had both enrolled in a post-baccalaureate program designed for wayward liberal arts students like us who had made a belated U-turn and decided to pursue a career in medicine. Prior to this, Kelly had been a Peace Corps volunteer in Chad, and to this day, actually, she maintains or continues to speak conversational French with the Nashville chapter of the Alliance Française, maintaining in this way, I guess, her membership in the Chadian diaspora. 30 years ago, Kelly was, as she is today, an exemplary human being, quick to laugh, kind, ethical, and marvelously interested in others. But on top of all that, there is her incandescent intellect and her clear as glass expositions of science and pharmacology. I hope you enjoy her talk.
I think I have this. Okay. Hi, well, that was really lovely, Anne, and it's such a pleasure to be here. And there are many familiar faces, people I expected to see, and then people that I'm pleased to see that from over the years that I've worked at Johns Hopkins and at Vanderbilt and in the infectious diseases domain. So, Anne, that was a very generous introduction. No wonder you're awake till 2 a.m. last night. I'm staying at her house, which is very generous. So I'm a tuberculosis researcher. I have been for a really, really long time, since residency. And so I know not everyone in the room is a tuberculosis enthusiast like I am, but I hope that over the course of today, you, whatever field you might be in, that you get some sense of the exciting things that are happening in infectious diseases and in therapeutics development. And for young people who are in the room, I'm also hoping one of my goals is to encourage more people to move into infectious diseases, choose this as a specialty, because so many of the unanswered questions are in infectious diseases, all of these diseases that emerge, year by year, decade by decade, and try to evade all of our efforts to thwart them. So anyway, I hope I can bring a little bit of motivation to those of you who are thinking about ID as a field. Maybe I should get to my first slide, Lynn. Okay, anyway. All right, good. So I'm going to talk about tuberculosis and give you a sense of what's happening in the field, as well as new tools. So I like this image of this metaphor of a dandelion for tuberculosis. It sort of symbolizes both the disease, which is airborne and can pass like the pieces or the seeds of a dandelion, but also in this slide, he says, in the same way social action can spread and take root, carried on the winds of our efforts and the global determination to overcome this disease. So it's not only thinking about the disease and the scientific pieces of it, but really how we can advocate for our specialty in our field in science, particularly in the given moment. And so I wanted to sidestep for a little. I think I would be a little remiss if I didn't bring us into the current moment and think about like today and how 2025 is feeling and sort of this time of uncertainty. And I went back to a slide deck that I made in September of 2020, and this is how it felt. I don't know if you guys like get a feeling as you look at this slide, but these were all of the things that were happening at the time that I made this slide deck for a talk. And so this was pre-vaccine, and the death toll from COVID-19 was exorbitant around the world. The kids couldn't be in school, so they were climbing on their parents' heads, and the parents are still trying to get their work done, right? And you see the people lined up at food distribution points because people were losing their jobs, living out of cars, and it was just a really rough time. Put on top of that, George Floyd's death, as well as Ruth Bader Ginsburg, and it was a tough time. And so I made this slide, and then I thought, well, what could 2021 potentially look like if we as humans in science tried to move things forward and get us out of this tough spot. And so imagining, wow, maybe there could be a vaccine, and actually indeed there was, and maybe people can get back to congregating and seeing each other's faces and not seeing them through masks, and we got to that space. So I guess I'm sort of inviting everyone in this moment to think, and this is way outside the topic of my talk, but I just, spent a lot of time thinking about, and I think everyone in this room thinks about, if this is how our current moment looks. You see measles coming into the hospital when we didn't used to see that, and all of these infectious diseases becoming more prominent. The gentleman you see here on the left side of your screen was the man who was shot when someone opened fire on the CDC. But then there's all of this technology, and so we're trying to find a way to use technology for good so it's not bearing down on us too much if you're clinicians and you're trying to do your work and yet you're bombarded by message after message. How are we going to use technology for good and for rapid drug development and all of these things? And then the Science 2024 is lenacapavir. You may or may not know is the molecule of the year. That is a Q6 monthly therapeutic for prevention of HIV. And so like imagine a world where we really have no more HIV infections because we use this tool in the best possible way. Okay, so back to the back to tuberculosis and the problem statement. So as Anne said, tuberculosis is still, it actually took the place of COVID-19. COVID-19, took the top spot for a while from TB, and then rapidly, we found solutions to keeping that at bay, at least to some degree. And then so tuberculosis now rose up and is the #1 cause of death from an infectious pathogen in the world. There were 10.8 million incident cases and 1.25 million deaths in 2023, and it's still a top 15 cause of death, which is insane given how long we have lived with TB and how much time we've had to try to work on doing better with this pathogen. And so now you've probably heard of multi-drug resistant tuberculosis. Now we have extensively drug resistant tuberculosis, and some of the new agents that have been developed in this century. Now we're finding that there are strains that are resistant to them. So we're again coming to a post-antibiotic era with tuberculosis. The good side of all of this, though, is that there are multiple new chemical entities that are in the pipeline, and I'll talk to you about some of them. I mean, it's a little bit of alphabet soup with drug names and things, but just to give you a sense of what's happening in the field. And then the latent TB tip of the iceberg is if 1 in 4 individuals living on Earth has tuberculosis in a latent form in their bodies, then how are we going to eradicate this millennia-old disease? And so if you're not a person who treats tuberculosis frequently, you've probably learned in medical school and thought about, RIPE therapy. So giving the first-line drugs for 6 months. So, I mean, you have to use 4 antibiotics and you have to use, and the treatment duration is 6 months for a bacterium, which is really dramatic. I think it's a little less bad than devil NTM, that someone at dinner last night called NTM, but it's still really pretty difficult to treat pathogen. And then those people who have TB that's resistant to rifampin and isoniazid, 2 of your first-line drugs, then now there is a second-line regimen, which works actually pretty well and is now just being implemented in the last year globally. But then if you can't use those drugs and you have extensively drug-resistant TB, then that's where we're talking about people taking medicines that are pretty toxic for 18 to 24 months, as Tony, who's here in the audience, well knows from his experiences in South Africa. And then even, some people say, well, we already have RIPE therapy, is fine, everyone does fine. But the reality is that it's really pretty poorly tolerated by a lot of people. So maybe in trials, people do pretty well with it. But in reality, when you're trying to treat people who have had transplants or are older and have other comorbidities, it becomes pretty tricky. And so some people in the field are really telling us we need to move less towards shortening the therapy and more towards making the therapy that we move forward in the future more tolerable for patients. And so that's a message that we're trying to hear in the TB trials arena. So you'll see here the development of TB drugs over time, with the last being developed, the bedaquiline, delamanid, protomanid are the last ones that have been developed in this century. But most of the drugs we use for TB were developed in the 1950s to 1970s. And then, of course, people thought that it was pretty well in check. And then HIV came along, and then TB just bloomed in the setting of the HIV epidemic. So what we're trying to do is put multiple drugs together and in a good way to develop the best possible treatments. And so I think we have a good sense of what we're trying to do with these regimens. And the World Health Organization develops these treatment regimen profiles, and so gives us some sense of like what we're trying to get to. So if you think about, so what I like about TB drug development is that it's really complicated. And so it's not like, you have a gram-positive pathogen, you're finding one new drug and you can use it. But now we're trying to put together 3 or 4 drugs over periods of time and intending that they be synergistic. And so if you think about the first-line drugs that we use, so there's isoniazid. It has really potent early bactericidal activity. So within the first 2 days of getting isoniazid, your bacterial burden is brought down by more than 90%. So those multiplying bugs are just easily killed by isoniazid. Patient feels better, much less infectious to others. And then rifampin is this unique drug that has this unique sterilizing activity that it can kill those bugs that are not actively multiplying, that are persisters, that are sitting kind of quiet and semi-dormant, but they can still be killed by rifampin. So it is the key drug in TB therapy. Pyrazinamide gives us this sterilizing activity only in certain microenvironments. So inside cavities and inside macrophages, it has activity only in acidic environments. So it allows us to shorten treatment by a couple of months. And then ethambutol just exists. It doesn't really add anything, but it prevents resistance to the companion drugs. So like kind of just by happenstance and brute force over the 1950s and 1970s, we came together, or the global TB trials community came together and developed this regimen that has all of these features. So now this is what we're trying to really to recreate, but in the modern era with modern tools. And then people would say, well, the current treatment, it's fine, everybody does fine. But the reality is that a lot of people don't really do fine with HRZEs, or with RIPE therapy. So there's not only it can be intolerable for some people, and there are all the drug interactions of the rifamycins, which are complicated. But in this recent trial, recently published, you can see in the standard of care arm, you don't really need to know what the design of this trial was. It was trying to shorten treatment with a couple of drugs, rifapentine and clofazimine. But what you see on the right-hand side is all of the people in yellow or blue, or in yellow, had unfavorable outcomes. And so if 25 to 30% of people who are eligible for a trial and kept track of and are taking their medicines have an unfavorable outcome, then that standard of care regimen is not very good. So certainly we could do a lot better than that. And the other thing to know about rifampin is that, I mean, it's a tricky drug because of the drug interactions, but also it's really not robust to lapses in adherence. So you can see from this study that even if you take between 90 and 100% of your doses, that the risk that you will have failure or relapse goes up 2.5-fold. And if you have even less than 90% adherence, then that goes up even further. So, stopping your medicines for a little bit of time, for tolerability, for, just, challenges you're having in your life, means that the bugs will start to regrow and that you have a higher risk of not having a successful treatment. So we definitely need things that are much more robust to, challenges with access or to adherence along the way. And then, so this is all a build up to like, what are we trying to do and what are the challenges, right? And so also just thinking about, as Anne said, that, TB and HIV are typically going hand in hand, and people with HIV are highly overrepresented among people with tuberculosis. So as we develop treatments for TB, we also have to make sure that those treatments will be available to and usable alongside the antiretroviral therapies that people are commonly using globally for HIV. And it becomes, the co-treatment is a challenge, the drug toxicities, the pill burden, immune reconstitution syndrome, treatment coordination, and drug interactions. But I think we're making a lot of progress in this domain as well, which I can tell you about. Okay, so that's all to say, like, this is a big problem, lots of TB, resistance is coming, we can't forget the people with HIV, let's I didn't even say like, let's remember the children and the pregnant women, although we'll get to that in a minute. But there has been a ton of progress. So since most of us went to medical school, even the residents in the room, there has been a lot of progress. So for prevention of TB, there's 1-HP. So 1-HP is 1 month of daily isoniazid and rifapentine. So you can cure your latent TB in 1 month's time, which is much better than the 9 months of isoniazid people used to need to take. I actually prefer the 3-HP, like once weekly for 12 weeks, which we can debate, but at least we know like in 1 month you can feel pretty good about curing someone's latent TB. The 4-HPZM, so that is we now have a 4-month regimen for tuberculosis for the first time for all comers, people with not severe disease, people with advanced disease. And so that is a combination of isoniazid, rifapentine, pyrazinamide, and moxifloxacin. So that's really been kind of a breakthrough. We just haven't had many trials trying to get TB treatment shorter and have not been successful. But now finally, we have a success. Now the trick is implementing that and thinking about the tolerability of those 4 drugs and the pill burden, those sort of things. So it's not really, there's still some room to, some distance to go before that 4-month regimen is usable and people know who are the best candidates for it. And then the BPAL regimen, also, this was a complete breakthrough. So this is bedaquiline, protomanid, linezolid, and a quinolone, usually moxifloxacin. So that 4-drug combination in a single trial called the NICS trial, they randomized people, or they didn't randomize anybody. It was a single-arm trial of people with extensively drug-resistant TB with no options, very sick, and everyone received this BPAL regimen. And the protomanid was registered on the basis of that single-arm trial among impossible or very hard to treat patients. And like when you talk to the clinicians who were part of that trial, it was like people rising up out of the dead. I mean, they got so much better so quickly with this therapy. So now for the MDR, multi-drug resistant TB, we have this 6-month therapy. But then now the bedaquiline resistance is starting to come, which I'll tell you about in a minute. So I think this has been like, 1 month for latent, 4 months for active drug sensitive, and 6 months for MDR TB. Like that's really been, revolution's maybe too strong, but like significant advances in the last like 10 years, 5 years either. But there's a lot to do. And this is just a slide to kind of give you a sense of all the different domains people are working in. And I'll talk through, did I do something? I'm good. Okay, great. Okay, good. Like I moved and like this thing. Okay. No worries. All good. So just thinking through what do we really need in the TB field. So I really think we can get to much shorter TB treatment. And especially at some point we're going to think through and learn how to use injectables so that we can finish off people's TB treatment with injections at the end that have therapeutic concentration for months to follow. Better translational models so we can accelerate drug development in a smart way. Stratified medicine, in TB, everyone gets the 6 months of the same drugs, regardless of whether you have pretty severe disease or you have really minimal disease. And then thinking about meningitis, cavitary lung disease, making sure we have good options for children, for pregnant women, prevention, vaccines, HIV, TB co-infection, and then now addressing this emerging resistance that's coming. So I feel like whoever wants to be in the TB field, there's a lot to do. And so you will have a lifelong, life's worth of work that you can participate in. And of course, there are so many infectious diseases that fall also into this category, as Dr. Andes would attest. Okay, so then I'll give you a sense of kind of what are the new drugs that we have, new compounds in development, and then some of the new tools. And so this is kind of a map of, unfortunately, they're not updating this as frequently as they used to. because of funding cuts to WHO and other organizations. But this just gives you kind of a sense of all the drugs that are in development for tuberculosis. And it seems a little bit complicated, but really there are kind of a couple different strategies that people are taking for drug development for TB. So one is take drugs we already know work very well, but that have pretty narrow therapeutic margins, and try to develop drugs in the same class, but that have a better tolerability profile. So one example of that would be, you see in this turquoise color, these new diroquinolines. So bedaquiline is of the drugs developed in the last century, the most potent sterilizing drug. It's really phenomenal, but it has a risk of QT prolongation. So you have to do some cardiac monitoring over the course of therapy, which is hard to enact in many places. And so, so now this TBAJ 876 and the TBAJ 587, alphabet soup, but these are two diroquinolines that are coming down the pike. I think the next to be registered will likely be the 876 compound, much more potent than bedaquiline, and does not have the hERG channel pieces have been dialed out of it, and so it should not have the same toxicity or need for cardiac monitoring. And then the drugs in the middle are linezolid is part of that BPAL regimen I told you about, and linezolid, you can imagine giving it over months of time. It has such mitochondrial toxicity and so much like bone marrow toxicity, so people become anemic, and then they develop peripheral neuropathy. And so like linezolid over months is like, no one likes that, right? And so, so there are these 4 drugs all in development to replace the linezolid component. So, and oxazolidine we can use for 4 to 6 months or beyond safely. And then there are all these, and then the other, so that's sort of take the drug classes we know work. And then the other strategy is to develop drugs against totally new targets, totally new classes of drugs. And so those are the ones that you see in pink and yellow and green and sort of grayish and sort of whatever that bluish color is. But it is kind of a rich pipeline, which I think is quite exciting. And so this is kind of how the clinical trials landscape has been changing over time. So sort of at the top left, it was all about like optimizing the rifamycins. How much rifampin can you give? Can you give rifapentine at high doses and get treatment shortening out of that? And then there's sort of the repurposing second line drugs. Can we get anything out of clofazimine? What can we do with fluoroquinolones? And now really the focus is all of these new chemical entities and trying to use them together. And so it becomes kind of a challenge if there are all of these, hundreds of different potential combinations. So if you have, 12, 15 drugs, and what are the potential 4 drug combinations you can use? I mean, it's really an explosive number of potential regimens. And so how do you narrow down which things to test? And so, so some of my colleagues at UCSF and at Johns Hopkins are applying AI to predict what would happen in relapsing mouse model experiments, because you can't run, thousands of mouse experiments. So you can run multiple 2 or 3 drug experiments and then anticipate based on what you've learned from them what would happen if you put 4 drugs together or these 3 different ones together. And so that is allowing us to get a sense of what we should move forward. And so here you'll see those drug combinations on the far left are those that are predicted to cure mice, to cure 95% of mice in the shortest period of time. And you can see the standard of care, HRZE, at the bottom to the far right. It takes 147 days to treat mice with the standard of care regimen for 95% of them to be cured. So the further left your regimen, the better chances that it has to be a successful regimen. But the thing is that it's much more complex than that, because the human disease is very different from mouse disease, which tends to be intracellular. And we have this really complex pathology with cavities and areas of necrosis in the lungs, and the drugs have to get into these cavities. And so now some of our colleagues are doing experiments where they can assess drug penetration into the kind of lesion. So they make this caesium in the lab, and then they introduce drugs to see how well drugs penetrate into the caesium. And it's not only how much the drug gets into the casein, but how well it kills the bugs that are there, because those bugs are very slowly metabolizing. They're hanging out. They're pretty hard to kill. They're in this sort of dormant space. And so now if you take those relapsing mouse, like normal mouse experiments, and then you layer on top of that drug penetration, drug killing in this type of complex lesion, now you're getting somewhere with ordering those combinations that should be carried forward into human trials. And then we're also getting a bead on patient phenotypes. So, there are people that have minimal disease, they're not all that sick, and really you can treat with almost any regimen and people will do well. But then there are those people that have more advanced disease, cavitary lung disease, high bacterial burden, and they are harder to treat. And so those are the individuals that will make your trial fail. If you have people with like hard to treat or high risk disease for relapse or failure, and your regimen is not good enough for them, then it's just those trials are not going to be good. So also like incorporating this kind of knowledge into our thinking about drug development. And so we have this really nice grant to develop this consortium called the Predictor Consortium that, and you can see the 4 PIs who are there. I'm the link to the clinical, and the other people are experimentalists. So Rada Savage does data science and modeling, Eric Nurnberger, preclinical in vitro and in vivo models, Dirk Schnappinger, preclinical in vitro models, and there are 6 different laboratories that can run experiments. And so, so that has been really fun. We've had this grant for a couple of years, and the idea is to accelerate the development pathway for drugs and regimens and to pick the best possible things to recommend to the trials networks that are running the trials. And this is just kind of a snapshot of all the things that are happening within this consortium. Okay, and so so I'm just going to talk about some ongoing projects that I'm part of. Not that these are the projects that are the most prominent or most exciting in the field, but they're the ones that I know the best because I'm part of them. But to just give you a sense of like the different domains in TB drug and regimen development. So how are we doing? Pretty good. Okay, so I usually number my slides so I know where I am, but I didn't do that. But I think I'm in good shape for this talk. So so this first example I'm going to talk about is treatment shortening. So what are some drugs we could put together to really try to bring treatment of TB down to 3 months, shorter than 3 months, because that's really where we need to get to for patients to feel like it's an improvement for them. And so with these relapsing mouse model predictions that I told you about before, we ran some modeling experiments to kind of predict the time it would take to cure 95% of mice with different regimens. And so you can see on the far left, the top regimen, this BPA-MZ, is the best regimen ever tested for people with TB. However, it was very toxic. The protomanid and pyrazinamide caused like pretty bad liver toxicity. So we know now we can't use those drugs together. In mice, great. In humans, these safety things rose up to the top. But these 2 second regimens are ones that we're testing through the Tuberculosis Trials Consortium that is funded by the CDC. And so you can see that those are kind of to the far left, as I talked about before. And then if you see on the bottom, that is those drug penetration studies that I told you about. And so each filled in box is over the course of a dosing interval for how many hours is the drug present in the lesion and at killing concentrations in that environment. And so you can see that each of those regimens has at least 2 drugs that are active for most of the dosing interval in the caseum, at least based on our preclinical models. And we predict that all drug regimens that have been successful have had at least 2 drugs that are present in the lesions at that time. And so if you map those 2 things, on the right axis is the mouse model, 95% of mice cured, and on the y-axis is the lesion coverage. Being in this rightward, upward box is where we're trying to be. So this trial I'm excited about. This is it's a 4-month treatment trial and then stop and follow for relapse. And it's fully enrolled. And It's been challenging with the government closed for 6 weeks with an ongoing global trial, but they're really incredible in their abilities to just make do and keep things moving forward. So hopefully we will have results in 2026 for the CRUSH TV trial. Okay. Oh yeah, someone made this is like where you I don't know what this is, like where you put the thing down and it crushes something. There's a word for it. I don't, yeah, so that's why it needs to be reworked. But this was our CRUSH TV. Anyway, so the second strategy I'm going to talk about is reducing toxicity. And so thinking about if this BPAL regimen was good, but the linezolid makes it so toxic that it's difficult for patients to continue and for programs to deliver, then what are some better oxazolidinones? So this is not focused on a more active treatment, but really on a less toxic treatment. And so this trial, you can see on the bottom right, is taking BPAL and then replacing the linezolid with two different compounds that are in development. So one is TBI-223, the other is sutazolid, but this will be a head-to-head look at the toxicity profile of these three oxazolidinones, two of which are new chemical entities. And then we can see if the microbiology, the rapid killing is similar across these regimens and figure out if one of these oxazolidinones should move forward further. This is my favorite thing, but that makes me cry a little bit. So this is a trial called Clobber TB, and this is kind of addressing this issue of emergence of bedaquiline resistance. I mean, that is really the cornerstone drug for multi-drug resistant TB. And so we're seeing all over the world bedaquiline resistance is cropping up. And so and the mechanism of resistance is through an efflux pump. So it also not only does that efflux pump kick out the bedaquiline, but it also kicks out several different companion drugs. So it makes it a little bit trickier to treat. And these compounds are typically resistant to bedaquiline, clofazimine, ethambutol, pyrazinamide, rifampin, isoniazid. So it's not so easy to treat as you can imagine. But we did this nice bit of work to try to predict using mouse model data what different combinations we could use to deliver multiple new chemical entities together to patients with bedaquiline resistant TB. Because really the standard of care is people are getting amikacin, they're getting meropenem with amoxicillin clavulanate, and all these really terrible toxic drugs you wouldn't want to offer anyone for like 18 months of time. So it's pretty terrible. So we kind of realized if we used these 5 drugs, protomanid, gamfebrol, sutazolid, carbodepistat, and TBHA-876, these are not names that would be familiar to anyone, but that we could, even with these resistant strains, do pretty well, at least by mouse model experiments. And then we also did some of this lesion penetration work to see, well, if we did that combination, how many drugs would get into the lesions at killing concentrations. And you can see from the far right in the casium that it's at least 2, if not 3, for most of the dosing intervals. So we felt really good about this. All 4 drug companies that own these assets were willing to be part of this trial and donate their drugs. They went to study section, got a 5th percentile, and went to council and earmarked for funding. But then all the trial sites were in South Africa, and so the NIH declined to fund the trial. So we're sort of trying to revamp and figure out where there are trial sites around the world where this bedaquiline resistance is emerging, and there's the capacity to detect it, because often you don't see it until the patient has been on a BPAL regimen and has been failing and not doing well. So anyway, just like pray to the NIH gods that we find a way to ultimately move this forward. And then just talking through a little bit HIV and tuberculosis co-treatment. I think in America, everyone knows Biktarvy and seems to be the #1 thing that people prescribe in HIV clinics, and actually primary care doctors who are taking care of people with HIV very common, easy to use medication, but really is not been introduced in many of the countries where tuberculosis is most common. And one of the reasons for that is that there just weren't drug interaction studies done. So, Anushka Naidu, a mentee of mine who is in Durban, ran this really nice trial to randomize people who have HIV not on treatments and tuberculosis to get Biktarvy twice a day or to get the standard of care, which is a dolutegravir-based regimen. And you can see, this is the graph of virologic suppression. And so you can see that the Biktarvy regimen just did equally well to standard of care. So we're hoping that this just is another on the box, the check boxes that you need for the company to introduce this drug into Africa and other settings where TB is common. And then just a word about prevention. I think we are ultimately going to move towards injectables for prevention. There will be a trial of an injectable bedaquiline that is coming down the pike in the relatively near future, which I think is really exciting. Because it's all about how do you keep people in care who have latent TB, regardless of their situation, right? If they're immigrants to this country and are still finding their way, but they need treatment, or people who have lives that are complicated, if you can get a shot and they know where to come for any sort of safety concerns, then this is a nice strategy. But this is just to let you know about, probably will, if this is successful, will be the shortest single drug therapy that we have for latent tuberculosis. This is a trial called Asteroid, and it's a trial of rifapentine given daily for 6 weeks versus standard of care. And we, at the beginning, this trial didn't enroll children, didn't enroll pregnant women, and was limited in its ability to enroll people with HIV. But we got a nice NIH grant that allowed us to do the pharmacology work to make sure that the doses that those populations achieve the exposures that we hope to get. And so now we're working on getting this set up so that now we can enroll these young children down to 0, that we can enroll pregnant women, and they will have an option for TB prevention, because those are really the populations at the highest risk for developing TB when they have a latent TB infection, because of the immunologic changes of pregnancy and the young children whose immune systems don't contribute as much to TB control. And so, yeah, and so looking forward, do you guys recognize these cartoons? Like, right, like most people, I don't know how many people in the room recognize this, but if you were a kid and you watched the Jetsons, and at the time it was like someone comes on the screen and I'm talking to them through the screen, that was like, whoa, like we didn't have cell phones. And then this is just like our Zoom, like this is our whole day now, right? And it seemed like like a futuristic kind of thing back in the day of the Jetsons. But I do think long-acting injectables is where we will get, as we have with HIV in treatment and prevention, the same pathway, I think, for TB prevention and for continuing and the last months of TB therapy. And so there's a bedaquiline long-acting injectable that has made it through phase 1 and has approval to become an ACTG, so AIDS Clinical Trials Group, or Advancing Clinical Therapeutics Globally trial. So we'll see that coming, that's under development. There are rifamycins that are in development and other drug classes. And so I think it'll start with latent TB because you can use a single drug in that environment. And then ultimately we'll figure out like what are different shots you could give to someone who is finishing out their TB therapy. Yeah, and so this is my sum up. Thank you for listening to a whole hour about tuberculosis. I think about it like 80% of the time, which, is like sad for my children and my husband, but it's nice to have an audience thinking about it. It's still the #1 infectious diseases killer in the world, which is just astonishing given the time we've had really to try to control it. And then highly drug-resistant TB is emerging pretty rapidly, pretty widely. Current treatments, I hope I've convinced you, are too long or too toxic or both. Certainly, we can say they're insufficient. But the TB drug pipeline, it's enriched. There are multiple new chemical entities that are making it now into the clinical environment for testing, which is exciting. First time in decades, we've had so many different groups working, like different drug companies and different clinical trials group working in this arena. And now we're also using data integration and cutting edge computational methods to really, I think, revolutionize TB drug development. The nice thing about TB is everyone works together because there's not really a profit motive for companies. And you have to use drugs in combination. So companies have to work together, which is very different than for oncology, say, or for other domains in medicine. And I think that the success rate of TB drug development will increase pretty markedly in the next 5 to 10 years. And then our grander hope also is that strategies and tools that are developed for TB regimen development could be beneficial to other fields as well. And, oh, I didn't expect that. So this is a slide, just one of my colleagues, Buddy Creech, who those in Peds ID maybe know Buddy. He gave a talk about measles that I saw recently. And just this, Roald Dahl lost his daughter to measles, and just a reminder of these infectious diseases and how we have these wonderful tools that we need to use and to try to reach people so they understand really what the meaning is of and the benefit is of vaccines to children, and so we all become adults. And these are my acknowledgements, and thank you for your time and attention.
Well, thank you, Kelly, and thank you for all the work that you do. I'm going to take chair privilege and ask the first question.
Yeah. Okay.
So you talked about prevention, but you're talking about prevention of progression of people who are already infected with latent
Yes.
TB to active TB. Do you want to touch upon the vaccine development world and
Yeah.
where that is and some of the challenges?
Yeah, great question. Thank you for asking it. So, so with vaccines, there are several different strategies. So one is prevention of infection. So you have nursing students who are all like, starting in
Pulmonary fellows who are going to be bronching.
Yeah, or like in India, you have your where in places where TB is pretty common, and you have all these young medical students starting who are PPD negative, and then over the course of their 4 years of medical school or nursing school, 80% of people become PPD positive. So there's this like prevention of infection in the first place, and then there is the prevention of disease. So you have latent TB and in preventing you from developing the actual disease. And then there's prevention of recurrence, or POR, which is you've already had TB and those people are at much higher risk of a second episode. So using a vaccine to turn on the right parts of their immune system so that they're less likely to have recurrence. But the thing is, so there was a really pretty fascinating recent clinical trial of a TB vaccine, and the investigators thought, okay, here's the type of immune response that we are trying to elicit with this vaccine, and so we're going to measure all of these things. And then what they did is they took people who, this is a prevention of recurrence, okay, so they had people who were getting their full ripe therapy, full 6 months. At the 6 months mark, they randomized people to get this new vaccine or to get placebo. Then they followed people over time. And gloriously, they all had the exact immune response that they had anticipated and hoped for. And ingloriously, the people who got the vaccine had higher rates of relapse than the people who had not. So I think like that just points to how in the TB vaccine field, we don't actually know what the correlates of protection are. I mean, we know certainly if you have TB itself that you're not immune to, and in fact, maybe have higher risk for a next bout with it. So I think we're pretty far from really understanding what we're doing. But there's a lot of movement, and actually there are quite a few things that are in the field. Yeah.
Gillian. I'm not a physician, and I've never heard so many drug names mentioned before in one talk. It was
a lot of sorry.
I was just wondering, so a few years ago, Catherine Barber's group, using non-human primate model of TB, showed that there was interaction between macrophages and eosinophils through GPR 183. So when you were talking, I was just wondering, are there at least preclinical trials where you've incorporated immunomodulators along with your therapies to enhance the functions of macrophages, maybe?
That's a great question. And happily, we have some basic sciences at Vanderbilt who are like macrophage specialists and immunologists, microbiologists. But I would say that, yeah, so like host-directed therapy, like in whom would it be beneficial? How do we use it? What are the right agents for that? There is some work in that area. I think probably the place where there's the most promise is in something like TB meningitis, where disability is high, death rates are high. And so much of the pathology is not the bug, but rather the immune response to the bug. And so finding ways to, and there are some early, like more observational studies, but of quite large numbers of patients of different agents that sort of tamp down that immune response. And people with TB meningitis are doing a little better. It's not yet subject to good randomized controlled studies. But then, yeah, I think what would be lovely is if we kind of had a sense of how much of your disease and your symptoms is related to the bug and how much of your immune response is like where it needs to be versus can we direct it differently, but I think it's pretty early days, yeah.
Hey, thanks. You'd mentioned how you said there's maybe not as strong a financial incentive for these companies to develop these drugs. Can you speak to what maybe are the main motivators for the companies, particularly to work together and have such a robust pipeline? And then also, is there anything that can be extrapolated to other antimicrobial development, like for other infections?
That's a great question. So at least in TB, there's been a lot of Bill and Melinda Gates Foundation investment, and so there's like a TB drug accelerator. So people who are really early, who have targets or who have early molecules, there's an accelerator program that people can be part of. So that's a lot of academic labs, but also industry, and then. There's an entity called the TB Alliance, so the Global Alliance for TB Drug Development. And so that's also mostly Gates funded, but it does bring together people who have compounds that are ready to try to move forward in different ways. And then they in-license those compounds, and then they can be tested through all of these different mechanisms of evaluating drugs, like in the mouse models and the human trials and things like that. But that, is kind of a unique academic, industry, governmental sort of partnership. So I think, I feel like for resistant gram negatives, that's sort of a setup where people are working together, and we have a mechanism for testing and bringing things forward that's a little bit more systematic and a little bit more cohesive would be very nice. So I will say that a lot of drug companies have gotten out of anti-infectives entirely. I think Pfizer was the most recent to get out of drug development. AstraZeneca did. So it's like a smaller and smaller groups, but I think it's a lot of this like ESG considerations that they want to do something for humanity. And so this arena of neglected infectious diseases becomes something that they'll invest in. But those are always kind of side fringe groups that are trying to hold on, and like bring things forward in the setting of a corporate environment where if it doesn't pay, it's really hard to continue to invest. So.
Great, thank you for a great talk. TB strikes me as an old disease that's been around for some time. What was striking is you said 1 in 7 people who have died of TB. And TB is evolving. Are we evolving? Have we learned? Are there people who are less resistant to TB? And we're learning from people who may not get this disease.
No, that's a great question. And I think there's a lot of work in these, I don't really do cohort studies, but a lot of like these large cohort studies that are enrolling many, many people and looking at like at ancestry of the humans. Or did your ancestors see the same TB that you were seeing because you're living in a different place than maybe your ancestors did? And so there's like a mismatch of like the bug that you would have grown up with had you not moved around the world to a different place. There's that like aspect of things. I think, yeah, and then there's all this kind of like who progresses, because if you say that that 1 in 4 people have latent TB, then you can't really probably treat 2 billion people. So how do you select those individuals that really are the ones who are at the highest risk to progress to having disease? And so there's a lot of work trying to, enroll thousands of people with latent TB and kind of get a sense of who progresses. But it's such a rare, it's a rare enough phenomenon that, if it's 1 in 100, 1 in 1,000, that you get very few people. So I think it's going to be a matter of bringing together these like giant data sets of people to try to understand who is at the highest risk. But yeah, in terms of coevolution, that's beyond my understanding. Thank you.
Great presentation. So in one of your earlier slides, you showed that 80% of the US counties do not have ID specialists. That sounds really scary, right? Because given all these things, so how are we handling all this development of like multi-drug resistant bacteria and other organisms?
Yeah, no, that's, thank you for asking that. So yeah, so he was pointing to on one of my slides as like, what situation are we in 2025? And 80% of counties in the United States do not have an infectious diseases doctor. And so then how do you, like I'm in the state of Tennessee, so how do we get to and help those individual patients who are in hospitals across Tennessee who don't have an ID doctor that they can call for a consult? So, we, at Vanderbilt anyway, we do a lot of telemedicine, inpatient telemedicine, and so the patient will be there and the nurse will be there, and you can get the story and all of the components and give like a nice high-level consult. And actually, even one of our fellows did a project looking at if you had an ID consult on someone with staph bacteremia, how did that change? How did that affect outcomes? And there was actually a mortality benefit, which you don't really see in fellow projects, like mortality benefits very often. But so we thought that was pretty impressive. But yeah, I think as technology improves and we can figure out how to get to these rural areas where, and then I also think about how to end the HIV epidemic particularly in Tennessee. It's a complex environment, and a lot of people who are at highest risk for HIV are pretty underground, and so it's a hard place to think about providing preventative therapy. And if you live in a rural area, you don't have access to coming to a major academic center. How do we get those therapies to people? Because if you can get a shot every 6 months and 100, this lenacapavir, I didn't mention this, but for HIV prevention, it was 100% effective. There were 0 cases of HIV in people who got lenacapavir for prevention. So like when have we had a tool like that in any, field of medicine? So yeah, so anyway, I think I welcome your thought. Over the day, I'll meet with people. I welcome people's thoughts about that.
Rob Hageman with Medical Oncology. Fascinating talk. Thank you. One of your earlier slides was talking about like the narrow therapeutic index with some of the antimicrobials, and I was thinking, okay, I understand that concept as an oncologist, but it got me thinking about all the parallels between this battle and cancer, and in particular the revolution that immunotherapies have been within oncology over the last decade or so. And I guess I was wondering, outside of their fabulously expensive cost, are they effective in this? Have they been tried? Things like PD-L1 inhibitors and CTLA inhibitors that enhance our immune system.
That's a great question. I guess I don't think we know very well what elements of the immune system we want to turn on and what elements of the immune system we want to tamp down a bit. I mean, it's always this balance with infectious diseases, like the host response and the bug and which is harming you. But yeah, I mean, that's a great question and certainly is a consideration. But
Great
then if you turn
project
the
for
immune
a
system on-
potential new interaction of hem-onc fellows and ID.
Absolutely, yeah. But then you get your iris, and then like now all of a sudden someone's on 4 liters of oxygen. So it's dicey, but yeah, for the future. Thank you.
Great. Well, thank you. And now I would like to call up Dr. Crines, our Artist of the Month, to do the drawing. And while Vince is coming up, I want to present you your own Dr. Crines original, and it's perfect for transport too, which we thought about. Yeah. Okay. Dun, 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 dun.
I don't think I've ever done this before. I'm very excited.
Yes. Okay. Oh.
This is going to look rigged. It's for Ed.
And Dr. Vasilevsky's. Oh, woo! Great. Thank you, Vince, for the donation and for the amazing art. And in particular, I want to thank Dr. Dooley again and